Good afternoon. Welcome to today's Grand Rounds presentation. I just wanted to let you all know that we're not going to be having a Grand Rounds program next week, so we will reconvene in 2 weeks. I wanted to remind you to fill out the attendance records, and also if you could fill out the program evaluations, and if you would be kind enough, give us any ideas that you might have in regards to future speakers or future topics. Today, I think we've got a really interesting topic, and we're fortunate enough to have a very excellent speaker. Our topic is Complementary and Integrative Medicine, and our speaker is Dr. Brent Bauer. Dr. Bauer is a consultant in the Division of General Internal Medicine at the Mayo Clinic, and he is also professor of medicine in the College of Medicine at the Mayo Clinic. He's been the recipient of numerous awards and honors, including Outstanding Teacher by the Internal Medicine Residents. He's also been extensively published in the field of complementary and integrative medicine, and I had the opportunity to hear his talk at this year's American College of Physicians annual meeting, and I thought it was probably the most interesting talk that I heard at that meeting. So with that aside, please welcome Dr. Brent Bauer.
Well, thank you. Can everybody hear me okay? How about way in the back? You guys are all afraid of me. Either I'm very intimidating or you guys will go to the same church I go to, because everybody has to sit way in the back. We'll try and keep it interactive. If you have questions, we're going to leave time at the end for questions too. And my final slide will be my email address. So if there's things, I know some of you have to leave because of clinical duties and so forth, so I'll certainly take care of those. But if there's questions we don't get a chance to address, shoot me an email later. I'm happy to try and have some dialogue and share some thoughts. I think the topic from CAM to integrative medicine, we're going to talk about how complementary alternative medicine has kind of morphed into this concept of integrative medicine. I'm going to share what we're doing at Mayo, not because I think Mayo Clinic has done it right and we're perfect and we know exactly what to do. I'm going to share some of the things we've learned along the way, some challenges, some opportunities. But the point is every medical center has its own culture, its own resources, and so forth. So what I'd like you to take away from this is the concept of what are we doing in this realm that our patients are very excited about. Right? I'll show you some data. About 60% of your patients are probably using something in this realm of CAM. And if we're not addressing that, if we're not meeting their needs, are we letting them be at risk for problems and so forth? And we'll discuss why that is. But the idea is leave here hopefully with some ideas of are there things we can apply in our own practices as one level. And then the second level, of course, is are there things in this realm that might help us care for ourselves? Because we have to care for the caregivers, right? We're all under stress, challenging times in medicine, whether we're doctors, nurses, pharmacists, physical therapists, take your pick. So I think there's some lessons here that we can apply personally as well as professionally. So at least that's going to be my goal. I have this nice professional clicker here, so that's beautiful. So I don't have any financial relationships. Unfortunately, I think that's a downside, not a good side. So I'm happy to be bought if somebody here has a independently wealthy or something. But short of that, so here's basically what we're going to do. We're going to talk what is CAM and how to become this integrative medicine. What's the research? I'll show you what we were doing at Mayo. Again, not that Mayo is the best research or the only research, but how do we influence our practice with that research? And then I think in the long run, improve the care of our patients and hopefully ourselves. So first challenge we have is what the heck is CAM? Because CAM, of course, means different things to different people. If we had this conversation in China, and we ask people, what is complementary alternative medicine, we get a very different answer than if we ask it here in the United States. So I think from our standpoint, most of us are practicing in a Western medicine model, a biomedical model. So we're going to think of CAM, I think, broadly in terms of things that aren't typically part of medical care from a conventional standpoint. So think of things like herbs and dietary supplements, obviously very popular, ginkgo here, hands-on therapies, so massage, chiropractic, kind of those types of things we can kind of get our hands around. And then acupuncture or some of the other energy therapies. These are kind of what we mostly kind of consider, that's sort of CAM, complementary alternative medicine. We sort of know what we're talking about, even though it's very hard, I think, to put a hard definition on it. So if it's CAM and it's out there, is it important to us? Should you be using one of your precious grand rounds to hear about CAM if it's just affecting a few people? And I've heard over the years, well, CAM is just about leftover hippies from the 60s. Once they die out, we don't have to worry about it. And if that's true, then we shouldn't be spending the time here. But these are the slides, the next few slides, I think I'll try and disabuse anybody who has that notion. These are basically two large studies, the greenish one, 2002, yellowish one, 2007. This is from the CDC, the NIH, 35,000 US adults. And they were asked a question, telephone survey, do you use CAM as part of your healthcare. And they were prompted for, this means herbs and dietary supplements, meditation, yoga, acupuncture, and so forth. And so you can see close to 40% of a general population said, yeah, I'm using something in this realm. You can see the little red bar, that's in 2007, the added question, how about kids in the house? Anybody in the children using CAM? You get the number about 12%. So right off the bat, I think this starts to build the credibility for why this is an important topic for us. No matter what we practice within the conventional system, a lot of our patients are obviously going to be using and incorporating these things in their practice or in their healthcare. Excuse me. So what do these surveys teach us about why do patients turn to CAM? Well, if you go down that list, back pain, neck pain, joint pain, arthritis, as you go through that list, you see a lot of pain. And I think, of course, if you start to think about it, I'm pretty good at helping my patients with back pain, but I don't typically cure them. I may get them the physical therapy, I may get them the exercise, maybe some medications, but oftentimes it's a chronic problem. And so if you think of those chronic things that conventional medicine hasn't been able really to cure, I don't cure a lot of anxiety. I can help with cholesterol and head colds, but as far as cures, probably not a lot of wins. So if we have chronic symptoms, and then we have an internet that makes it very easy to find other information, it sort of doesn't surprise us. I don't think it should surprise us too much that our patients are looking for what else is out there. So I think the growth that we've seen over the last 10 or 20 years in patients using more and more things sort of makes sense. It just sort of fits with aging population, chronic conditions, and a lot more easy access to a lot of information. Now, what do they do when they go to CAM? What are the number one things? Well, the number one thing is natural products. Sort of fits, I think, because if you think of patients, most of our patients sort of have a pill culture, right? If we have a problem, there should be a pill for it. And of course, if a pill is natural, it's even better because it's safe. Natural means safe, right? That's one of the mythologies we have to work around. Then go through there, deep breathing, meditation, massage, yoga, progressive relaxation, guided imagery. A lot of things geared primarily at stress. And again, think who's more stressed right now than Americans. And we'll talk about some of the consequences of stress and why CAM is meeting a need that we don't have all the answers for from a conventional standpoint. So the point is there's a lot of reasons why our patients are using these things. The idea, hopefully, is that you kind of think, yeah, this is something in my practice I better be aware of. We've had other patient or colleagues, though, at Mayo, for example, who said, well, this is national data. When they come to Mayo Clinic, or maybe here when they come to Greeley, our patients are really sick. They're really sophisticated. They're going to have all these things. So this doesn't apply to our population. And I'll just tell you that we've done a number of studies like this with Mayo patients, where if anything, our patients' usage is higher than that national data, probably because they're sicker and they have more problems and so forth. So just the opposite of what I think a lot of folks thought. We probably better pay even more attention when we're seeing patients with lots of issues and challenges. So this led us back in 2001 to recognize that we didn't have all the answers. Patients were asking us questions. They were coming for a heart transplant, and they whipped out their list of supplements and said, I'm taking 40 supplements. Or they said, I want to have massage therapy as part of my delivery experience. And we had really no good answers. We didn't have the knowledge base. We didn't have the physician, nurse, or other practitioner expertise to tell our patients what to do or what was safe and what wasn't. So we created this program. Back then it was called the CAM program. Now we use the term integrative, and we'll talk about that in a few minutes. But the idea of let's look at research, education, and practice issues around this realm of CAM so we can come back and help our patients. And we created what's probably not a too unusual structure. We had somebody run our practice, our education, and our research arms. But really the first several years, the focus was on research because we recognized we didn't have all the answers. Most of us weren't trained in integrative medicine, yoga, herbs, acupuncture. These weren't on the radar screen when I went to medical school in the early 80s. So there's a lot of catching up to do, and for us that meant doing a lot of research. So what I'm going to do is I'm just going to share a few of the research areas, some of the things we've done, first in the inpatient, then the outpatient. Not all of the research we've done, just to give you kind of a high-level view. But what I want to show, hopefully, is how the research answered questions we had from the practice and our patients, and then that research was then used to transform the practice. And then is that a model that we can use for other questions that we're currently facing in our own practices? And hopefully the answer is yes. So this is St. Mary's Hospital, one of the two hospitals in Rochester. In this particular instance, we started working with our cardiovascular surgeons around a question of massage. And of course, massage typically, I think most of us probably still associate massage with a spa, a pampering. It's kind of over there. We wouldn't think of it as something we would drag into the question of open heart surgery. But that was the question here, because the surgeons about 8 or 9 years ago asked the question, how do we reduce pain in the postoperative setting? And they convened a team and had the pharmacists, they had the surgeons, they had the nurses. We were at the table. And they did a lot of cool things. They changed the chest tube so they slid out easier, different anesthesia, different narcotics. But the nurses really kind of said, we spend the whole day with the patient. You guys see him for half an hour. We think they would really benefit if we had things like music therapy or acupuncture or massage. And to the surgeon's credit, they didn't say, well, that's all a bunch of wacky stuff, forget it. They said, if you think you can help our patients, you have to show us. But if you can show us, we'll incorporate it in the practice. And so massage was one of the first things the nurses said, we really think that would be helpful. And you have to go back 8 or 10 years. If you look at the literature, a lot of literature said don't massage anybody after surgery because you might induce clots or bleeding. And so it was kind of a no-no. And so here we are saying, well, we're going to try it. So we did a very small trial, a pilot trial, to see if there's any harm and then look secondarily for outcomes. We did a control. So it's always challenging in this realm when you have hands-on therapy. How do you make fake massage over here and real massage? A little challenging. What we did, though, is we had the massage therapist who spent 20 minutes with the patient. She spent 20 minutes with the controls. She didn't do massage, but she still talked to them and had the caring presence. So you're kind of controlling for the human factor because maybe it's not massage, maybe it's just that somebody cared for you, put you in a quiet room. So it's not a perfect control, and we can talk about that in the question and answer session. But pretty good research, small numbers, and yet we still reach statistical significance on the level of anxiety those patients experience throughout their hospital stay. So no massage versus massage, and the same thing for pain. Pretty significant, statistically significant, even though it was a very small trial. Wasn't really meant to be showing these as a statistically significant change, but they were. And it was enough for the surgeons to come back and say, well, we're intrigued, but we're not 100% convinced. Do a larger trial. So we did about 120 patients, 113 finished that trial, and the same thing. This time we did massage in day 2 and day 4 to see if we could get some sequential effects or kind of a build-up effects. And we saw a statistically significant reduction, again, the same things. Plus we asked about relaxation specifically. We asked about satisfaction when it went up. And that was enough at that point for the surgeons to say, we believe it, we're going to incorporate this. And they hired massage therapists as part of the routine aftercare for open heart surgery. And anybody here a surgeon? So you got to be real careful because surgeons are pretty competitive, right? So down the hallway, the colorectal surgeon said, we see what you're doing over there in cardiovascular surgery. Could we do it over here? And so they asked us to come and we ran studies with them because maybe their patients are different, right? This incision's different, the patients are different. Could massage work? And it did. And so they hired massage therapists. And then that went through the thoracic surgeons and the breast surgeons. And pretty soon the Department of Surgery just went ahead and hired massage therapists to make it available routinely. Down the hallway, the cardiologist said, our patients are very stressed when they come for a cardiac cath. Could you help us with that? What if they got a massage just before they went in for the cardiac cath? And then, of course, it wasn't too long before our staff started saying, you're getting massage here, here, and here. What about us? So we started looking at the staff who wear the heavy lead aprons in the cath lab. A lot of back injuries, neck injuries, disability. We actually brought a full massage table into one of the empty spaces, and in between cases, we couldn't interfere with the flow of work, but we had table massage for them. Nurses in the inpatient units, nurses in the psych units, a lot of stress, bring a chair massage. And so all of these things had outcomes that we were able to come back and say, yeah, there's something here. And so this really changed the practice, and if it works, I'll show you a quick video that kind of summarizes this, and I think is important because it kind of gives the idea of what Mayo thinks.
Thousands of people have open heart surgeries, bypasses to reroute blocked arteries, valve repairs, and more. And if you ask anyone who's had heart surgery, they'll likely tell you the experience was stressful and at times painful. Doctors at Mayo Clinic want to change that. They're starting a new program called the Healing Enhancement Program. The goal is pain-free open heart surgery. Yes, this includes medications, but it also includes complementary therapies like massage.
You want to get it right in the basket.
To Rod Anderson, playing this round of frisbee golf with his buddies is a particularly pleasant experience.
Good shot.
You see, today is the first time Rod's been on the course since he had open heart surgery to repair damage caused by an aortic dissection. Rod said, sure, it was uncomfortable to have his chest open for surgery, but that pain was nothing compared to...
My back was killing me. It's almost indescribable, the soreness.
Rod's surgeon, Dr. Thoroff Sant III, says you get sore after surgery because...
When we open the sternum to do the surgery, the rib cage spreads really in the back, so people experience pain between the shoulder blades.
Medications helped ease Rod's sore muscles, but he said massage helped more.
It helped my stress. help the pain on my back.
Massage is just one way experts at Mayo Clinic are working towards their goal of pain-free open heart surgery.
We're trying to see if we can reduce pain, tension, and anxiety.
Why? Because when people are relaxed, they feel pain less. So in addition to massage, the program includes guided imagery, where patients listen to special CDs, stress management counseling, and soothing music in patient rooms.
The aim of that program is to address all of the needs of the patient.
So that patients like Rod will feel better faster and get back on the course of life sooner. Dr. Sant says he and his colleagues are addressing every aspect of open heart surgery to find ways to make the experience better for patients and their families. Again, he believes if patients are more relaxed and feel better during the ordeal, they will return to a full life faster. He and his colleagues are working on studies to see if this is true. For Medical Edge, I'm Vivian Williams.
So this is part of the news feed that Mayo creates on a regular basis, and I just think it's kind of interesting to kind of see that high level of buy-in to the concept of we're bringing something additional to the table. This isn't about replacing the best conventional medicine. It wasn't, don't have your bypass, don't have your valve replaced. Let's have your valve replaced, but can we help you through that experience reach out with something we didn't have before? Now, how do we spread this through the rest of the hospital? Because the surgeons could afford to hire massage therapists. I'm a general internist. Ostensibly, I lose money every time I walk on a hospital floor. So I couldn't turn to my leadership and say, let's hire a bunch of massage therapists. We couldn't afford. So we've had to go to a fee-for-service model. We've created a model where we can have massage therapists for about $1.50 a minute, work with patients throughout the hospital. So it's available to anybody. And most patients in the hospital are looking for about a 15 or 20-minute massage is what we find. So we've actually tracked through a couple studies what happens when they go home. They get this big hospital bill, insurance, oh, you have to pay $30. It's massage? Oh, guess what? They all pay. We haven't had anybody stiff us on the... So I think the value of it is there. It's a model. And of course, the question is, what about people who can't pay? We'll talk about our volunteer services. We'll also talk about some other strategies. But I think the idea of can we make it work even in a system as constrained as most of our medical systems are, I think the answer is yes. May take some creativity. One other quick example of another surgical partnership where we did some nice research is in the realm of acupuncture. This was looking at nausea. And again, our cardiovascular surgeon said, we're doing all this great stuff with pain. We're using more meds. Meds are causing more nausea. Can you help with the nausea? And so we snuck in right before pre-op, right before they got up to the operating room, and put some needles in, had the patients maybe 15 or 20 minutes with needles in, and then let them go to surgery. And of course, you have to be very careful you don't interfere with the flow of surgery and all the things because timing is very critical. But with that very brief encounter right before surgery, nothing else, we were able to show a statistically significant reduction in nausea on days 2 and day 3. And patients received acupuncture for those who didn't. So again, is this the answer to everything in the world? Is this guaranteed to make everybody not have nausea? No, but if we can reach even a small percentage of our patients who therefore don't have to use as many of the antiemetics, they're often extremely expensive, we begin to see where maybe some of this stuff starts to make sense. Not only are we helping our patients, but maybe improving the bottom line. So the cardiovascular surgical team came up with this idea of let's make sure patients are aware of all this. They call it a healing enhancement program. And what they're basically doing is highlighting to patients as they come in for surgery, as part of your care, you're going to have access to things like acupuncture, massage, hand massage is the volunteer service, art at the bedside. We've got volunteers from the Art Center in Rochester, not art therapists, but just artists who have not approved non-toxic materials, just do artwork with patients. We do a number of forms of meditation training, biofeedback-assisted training, aromatherapy. A number of, some of the rooms are wired with Bose units, they're very nice surround sound, thanks to a generous benefactor. Most of the rooms have access to at least to a CD player where we can actually bring in guided imagery and different CDs. The TVs are all wired with the video on demand. We have about 5 or 6 channels just dedicated to relaxation. So you can watch waterfalls, you can watch the ocean, you can be walked through guided imagery. And it's really interesting when I haven't done rounds for a little while this year, but when you take a team of residents especially into a room, they're all tense, they're all worried, they got lots of things on their plate. Patients are very anxious, and there's a news channel, death, destruction, economy's going down. And then you walk into that same room and you switch the channel to one of the video on demand, and you say, oh, here's the Finger Lakes of New York waterfalls. What do you think of that? And you'll see the patients obviously come down a notch. But you watch your team, you watch these residents who are all, you'll see their shoulders come down. Again, just working with the environment, doing some simple things sometimes. It doesn't always have to be hiring a massage therapist or hiring an acupuncturist. Sometimes we have to go back to what we knew 20 or 30 or 40 years ago. Partnerships with patient education, they do a tremendous number of things at very low cost, so we can offer a lot of things to patients through them, our volunteers. So it really is meant to, I think it has to be kind of a coordinated, cross-disciplinary, multidisciplinary approach to achieve the best outcomes in a system of constrained resources. Outpatient, we've done a lot of research on herbs. I won't go over all of those, but ginseng's one of particular interest. We did a nice study with our folks in oncology. Fatigue is probably one of the most persistent problems after cancer. Most patients will complain about that above everything else. So we said, well, what about ginseng? Because there's some interesting data that ginseng could help. So we did a large trial and it actually seemed to help. And then we did another trial and confirmed, yeah, it seems like this is not a magic bullet, but it does help a lot of patients and it's very safe. So we've actually worked with the Ginseng Growers Cooperative over in Wisconsin. They actually have on their website, they prepare a ginseng preparation that mimics what we used in the study. So we're able to direct patients for something else to try in addition to good nutrition, exercise, and so forth that they're already hearing. We've also had a number of studies that showed negative results. We tried ginkgo to prevent chemobrain. We tried a soy drink, which should be anti-inflammatory and might have helped fibromyalgia. Both those studies turned out to be negative. So the point is we're very committed to producing good science. So if it's negative, we publish that at the same level of intensity that we publish the positive results. So the goal is to have our patients make informed decisions. If something doesn't work, something's going to harm them, we've got to be right there to help them, because otherwise they're getting bombarded by the TV news, their friendly aunt down the street who thinks they ought to do such and such. So it's our job as healthcare providers of every stripe to make sure they have access to that good information. Acupuncture in the outpatient setting, I think this is an interesting trial, and there's a couple points I think are worth paying attention to. Small trial, as most of these are, because the funding usually isn't tremendously high. But this was a group of patients, mostly women, who were going through our fibromyalgia treatment program. And half of them got, and so our fibromyalgia treatment program is usually 2 or 3 days, a lot of cognitive behavioral therapy, a lot of restructuring of how they think and so forth. Half the group got real acupuncture, needle went in the skin. The other half got a sham acupuncture, where they got poked, they couldn't see it, and then there was taped onto their skin, so if they did cheat, it looked like there's a needle in the skin. So a reasonable approach to doing sham acupuncture. What's interesting with that approach, there was a statistically significant difference in fibromyalgia impact questionnaire, the FIQ, 1 month later. And same thing for pain and fatigue, or anxiety and fatigue. Anybody here take care of patients with fibromyalgia? Anybody here have fibromyalgia? So I mean, it's a difficult disease, right? We don't have all the answers. Conventional medicine, we can help a lot, but sometimes I have a lot of patients who still struggle. So this gets my attention. What's really interesting is those same patients were sent the same survey instruments 7 months later, and there's still a statistically significant difference between two groups. Now, the docs in here are, that's a bunch of, that couldn't possibly be the case. But interesting, there's work coming out of the University of Michigan, Dr. Richard Harris and colleagues, where they're actually looking at opioid receptors in the brain. And they do real acupuncture, needles go in the skin and so forth, and the mu-opioid receptors in the brain actually increase in number compared to if you do fake acupuncture or some acupuncture off a different point. Now, does that mean that we now have the mechanism and we know how acupuncture works? Absolutely not. But again, it kind of goes to that point, could there be a long-lasting effect of acupuncture? We have a lot of our staff nurses, or a lot of our secretaries with neck pain, back pain, went through physical therapy. A lot of them come back, get 3 or 4 treatments of acupuncture, and we see lingering effects. So I think it's plausible. I'm not going to say it's the mechanism, but I think it's plausible we're doing something in the CNS that we don't fully understand. But you see data like this, to a certain extent, it doesn't matter. If I can help my fibromyalgic patient do well for 7 months with 6 treatments of acupuncture, pretty low cost, now we have to start getting excited, because I don't have a greater or a better alternative for that patient who's still suffering. So this is where we start to kind of figure out, how do we wed these things in a way that's evidence-based but can help our patients. Yoga, I just include, this was another small study we did. This was on New Year, but the day after New Year's, we said, a lot of employees want to turn over a new leaf. They're going to try and get healthy. I think they might come in for yoga. We were going to do it over the lunch hour, but of course, nobody has a free lunch hour. Nobody wanted to stay late, so we said, we're going to do it at 5 o'clock in the morning. Yeah, who's going to come to Rochester, Minnesota, 5 o'clock in the morning and do yoga and get yelled at about how to eat better? Well, it turns out we had slots for 50 patients. That first week, we had like 350 people sign up. And again, it's just, I think, kind of reflects the fact we want to be healthy, right? But we're so busy. And by the way, the old message, eat more or eat less and exercise more and get on your, that doesn't resonate with everybody. And what if you're a little overweight and you can't do the hardcore spin class or whatever? So I think we attracted a whole lot of folks who otherwise were kind of disenfranchised, and they came in, and you say, well, gee, that's pretty interesting. That first week, they're all enthusiastic. It's a new year. I bet they all dropped out. We had like 2 people miss more than 1 session that whole month, coming in at 5 o'clock, 6 days a week. and they did power yoga, and they got a lot of instruction, and they had these tremendous outcomes in a very short period of time. Flexibility, weight, blood pressure, stress levels. I mean, really cool stuff. And again, now we have a number of yoga classes offered throughout our employee wellness system. We have some introductory yoga videos we give our patients who want to start. So again, the idea of simple things can lead to big changes. And again, yoga instruction isn't that expensive, and it's really not that toxic for most people. Now this brings back to something I alluded to earlier on. We seem to be spending a lot of time at Mayo focusing on stress in this realm. And I think this is just meant to be not a read every detail slide, but this is just my quick summary of about 30 years of research on stress. If you look at people undergoing chronic stress, we know a number of things. For example, we know that wounds heal slower if you're under stress. So now think about your hospital patient, their chest is open. Do you really want to optimize the wound healing, or do you want to minimize wound healing? Immune function. If we're under chronic stress, immune function comes down. So again, think of all your patients who are undergoing stress. Are we targeting that? We obviously know a lot of things about the heart. We know it raises blood pressure, does all kinds of stuff to viscosity, more strokes, more heart stuff. Genetically, under chronic stress, we flip off some of the anti-inflammatory genes. We flip on some of the inflammatory. So we're more inflamed under chronic stress. The kids get more illnesses under stress. Not when they're stressed, when their parents are stressed. Parents are stressed in the household, kids get more illnesses. So as you start to go through all this data over and over and over, what starts to emerge, at least in my mind, is something that's probably as big a risk factor as hypertension and cholesterol and so forth. All of our patients know their cholesterol numbers, their hypertension, their blood pressure. Nobody ever thinks about stress in that way, but I think we're missing an opportunity. And again, this is where I'm kind of limited when I practice conventionally, because I can tell my patients about exercise and nutrition, but what else do I have to offer them? Well, when I can turn to the integrative medicine realm, I got lots of things. So one of the big things, of course, is meditation, or the kind of the mind-body programs. This is the first app Mayo included or developed. Mayo Clinic Meditation is based on something we call SMART, Stress Management and Resiliency Training. This is the brainchild of Dr. Amit Sood, who's Indian descent, been meditating since he was a little kid, and he recognized that a lot of the meditation programs in the country, like mindfulness-based stress reduction, MBSR, you're familiar with that, 8-week course, very difficult, you got to kind of empty the brain. Most Americans aren't wired for that. We're not going to do 8 weeks of training, and we're not going to sit there and try to empty our brain. So he said, what are the elements of meditation that anybody could learn and kind of strip away the mysticism, if you will? He teaches the patients first the neurobiology, what's happening in the brain, what's the amygdala, what's the limbic loop, the prefrontal cortex. And once they understand what stress is doing on a negative level, then he starts them into paced breathing, which is a component of most meditative practices, and then starts to have them focus on things like compassion, forgiveness, and so forth. So pretty simple, about a 90-minute training. We get most people going. They go home with a DVD. And we've had tremendous results with all kinds of patient groups. We can actually demonstrate improved resiliency using things like the Connor-Davidson scale for resiliency. Obviously, reduce stress. On the other side, we've done a ton of work with our staff population. The last two are worth noting. The Department of Medicine division chairs, all of our division chairs now go through this training as part of their duty of leadership. And every first year Mayo Medical School for the last couple of years now, that first week of training, they go through this SMART training. And again, I think that's not to suggest that that's what everybody should do, but I think it reflects the fact that at a leadership level, Mayo Clinic is saying, we have to take care of the caregiver, and this is one of those tools that they should have in their disposal. So again, just kind of reflecting this fact that I think we can reach into our patient population, take care of their stress. We can also take care of ourselves a lot better. Oh, I mentioned the volunteers, because a lot of you are saying, well, heck, I'm in a rural practice, I'm living over here. I don't have access to massage therapists, acupuncturists. What am I going to do? Well, we've had tremendous benefit from working with our auxiliary and our volunteers. So the Caring Hands Massage is a very simple course. It can be trained very quickly. Now they can go into a hospital room, hold the patient's hand, do a gentle hand massage. They can work with the family members, loved ones in the intensive care unit, families fluttering around, all anxious, making things much more dramatic. Bring the patient's family out, do a hand massage, changes the whole dynamic. So again, having that available allows us to reach a lot of patients, but it also helps the volunteers. We've had a tremendous spike in volunteer requests because people say, that's what I wanted to do. I don't mind giving out cookies. I don't mind, giving directions. I wanted to get in there and really help people. So all of a sudden we see our volunteers spike because they want to be involved. So again, reaching into that. They also run our animal-assisted therapy. This is Dr. Jack. Dr. Jack is just retired last month. Dr. Jack got very famous. He had his own book. The foreword was written by Barbara Bush. And then Ty Warner is a patient at Mayo Clinic, and he runs Beanie Babies. So he said, I think you need to have a Beanie Baby of Dr. Jack, so he's got his own Beanie Baby. Most of our caring canines, which is the volunteer service we run, these are teams of owners and dogs who've been certified. They go through training, and then on a volunteer basis, they come in the hospital and visit with patients. Obviously, a tremendous amount in the pediatric area, but a lot in psychiatry. Really very impressive things happen in psychiatry when you bring a dog team into that. But again, relying on volunteers where we can't reach everybody with salaried FTE. What else can we do? What else can we bring to the bedside? Maybe it's the CD, maybe it's the video on demand, but there's lots of things we can do that don't necessarily require new resources. And I was so this is the chapel at St. Mary's Hospital, and I just include this because if we start to think a little bit about not only the things we do, but where we are, the healing space concept. So a lot of patients, a lot of staff, you'll find in the chapel, obviously before big surgeries or after surgeries and so forth. So there's kind of a way to kind of incorporate the spiritual very directly, but we also know a lot of patients aren't getting all their spirituality from an organized religious perspective. So we've created a lot of quiet spaces, meditation spaces, non-denominational, that patients and staff can go into. A lot of green space. I see you guys have kept a lot of green space around the campus. I think a lot of people find meaning or spirituality recognition from being connected to nature. Artwork. You guys are kind of loaded with artwork here as you're walking through the halls everywhere. But I think that's another thing. A lot of patients find artwork to be something that refocuses, redirects, brings meaning. This is the big archway over one of the entrances at the hospital. This is one of the this is a very nice meditation room given by a benefactor, but again, it incorporates art. It brings this quiet space. And again, you almost amazing what you see walking through there if you go through there, the staff, the surgeons, the nurse, the pharmacist, and then just an endless parade of patients looking for that place to kind of have that anchor, that time to be quiet. And again, not everybody can make something quiet, but we can find quiet spaces. We can direct people to the green spaces. We can help them understand where the healing spots are on almost any campus. All right, so for the hardcore skeptics, I put in Dr. Dean Ornish, because you may still be at this point saying, well, this is really cool. Sounds like you're doing some kind of foo-foo stuff. A little of this, it's all lovey-dovey. I need hard science. And so this is where I think we get a little of that. Everybody familiar with Dean Ornish? He's been around for 30 or 40 years. He's the guy out in California. You're about to have a heart attack. You can either have bypass, you can come with me. Come with me, I'm going to teach you nutrition, exercise, stress management, and you got to get in a support group. And he followed those guys out, and the guys who did the lifestyle stuff did a lot better. 30 or 40 years he's been preaching that. We're Americans, we don't listen, and so now we've never been more unhealthy. So he took that same process. He said, I want to show you at a genetic level, down to the chromosomal level. And so what he did is a study on telomerase. Are you guys familiar with telomeres or telomeres? So this concept of chromosomes that have the little caps, and I'm very simplistic in this, so don't go too deep with me, but think of it like the shoestring, right? The shoestring's got the little cap, the cap comes off, the shoestring frays. Chromosomes contain all our DNA, it's all coiled up there. The cap comes off, the DNA can uncoil, it can break, so that when that cell has to make a new copy, the genetic blueprint's not as good, so the next cell's not quite as good, so that's how a lot of people now view aging as happening. Or what if that piece of DNA breaks off and that piece and they meet and they create a mutation? Well, that might be cancer. So that was a Nobel Prize in 2008, 2009, somewhere in there, for the folks who recognize that telomeres, the caps, are very important to our health. And we also, unfortunately, know that most everything we do makes them get smaller, right? So we age, they get smaller. We smoke, they get smaller. We get stressed, they get smaller. We eat junk food, they get smaller. So almost everything in American life, and now you start to say, well, that's interesting because we've never been more unhealthy and we're fatter and more chronic disease. So you kind of start to think, oh, there's something there. So he said, well, look, I've been working on this health stuff for a long time. I think I'm going to be able to impact telomerase, the enzyme that makes that telomere. So he took his usual plan, pretty much a plant-based diet, whole foods. Look at it. If it's got 14 ingredients, I'm not eating it. It's got to be whole foods, mostly plant-based. These were older guys with prostate cancer, and I think that's important because if this is a study on 20-year-old college kids, it doesn't mean anything to me or my patient or the person with the disease. But this was patients with the disease. They had active prostate cancer. They were 75, 80 years old. So these guys were only walking 30 minutes, but they had to do it every day. And then he had these guys do 60 minutes of stress management every day. Yoga, meditation, didn't matter what it was, but 60 minutes every day. And then they had to have a support group. For us, we're going to translate that in our community or connectedness or tribe. You got to be connected somewhere, right? If you're sitting in an apartment and all you do is watch TV all day long, nobody talks to you, whole different outcome for that person than somebody who's connected. That's what he also said. You guys take a little fish oil, but this was not, in my mind, a dietary supplement study. This was a lifestyle study. And what he showed was a statistically significant improvement in telomerase. So the enzyme was low at the start of the study. 3 months later, nutrition, exercise, stress management, 60 minutes a day, and the community/connectedness, significant rise in telomerase. Now, this is not to say that he cured prostate cancer, but it's interesting in that study, in that short period of time, there was a trend for the PSA to come down. So you start to, that's interesting. So what I can take out of this is he's probably, with lifestyle, which is including a lot of the things we're thinking about from an integrative medicine standpoint, probably optimizing cellular health down to the chromosomal level. And this is sometimes where patients start to resonate a little bit more because they've heard eat better, exercise more, and they ain't doing it. But a lot of times they'll come to the table and they'll hear that we're interested in talking about stress or we're talking about acupuncture, and that sometimes opens the door to doing some of the 90% of what we were doing from a conventional medicine standpoint, but not getting listened to. We add a few other things, and all of a sudden we've got patients in a much different venue for promoting health and wellness. So I think we're starting to get some of these genetic signals. We've got some of the MRI studies that show us how acupuncture might work. This is where we started then creating a clinical practice at Mayo. Back in 2004, started out with just one doc and a nurse, and have rapidly grown to more docs, number of massage therapists, 4 or 5 licensed acupuncturists, the caring canines, animal-assisted therapy, music therapy, a lot of volunteers, a lot of work with our patient education folks. The nice thing is it's all integrated. So at Mayo, if I order an EKG, I'll use this electronic ordering form. If I order acupuncture, I'll use the electronic ordering form. If my patient goes to see my colleague who's a conventional doc, 2 doors down will be the acupuncturist in a very similar room, a little nicer amenities, but very similar room. And that acupuncturist will document and dictate in the same chart or the same electronic record as my colleague. So it's very much part of the practice. It's not that you go over here to see the weird stuff and here's real stuff. Nope, it's integrated. It's part of the practice. And I think that seamless connection really helps people understand the value. If you like numbers, this is just to kind of show a steady growth. The demand has actually completely outstripped our ability to even come close to tackling it. Mayo's sort of under a hiring freeze to a certain extent, so we've been really chronically short of acupuncturists and massage therapists for sure for the last 2 or 3 years. So the numbers keep going up because we have a lot of volunteerism. People work people in and we do what we can, but clearly the demand is just going to continue to grow. And not because they're replacing conventional medicine. They're looking at conventional medicine. We love Mayo Clinic. We're here for complicated things. But boy, if you could offer one more thing or help me address these other needs, then we really start to hit home runs with patient satisfaction. If you have patients who are interested, where are there resources? You can certainly direct them to mayoclinic.com. There's a lot of information there. It's very basic. It's very conservative. Mayo's surprised, a fairly conservative institution, but a lot of information that you can share, and it doesn't cost anything. I think we brought some of our patient education materials. We've got a number of DVDs, CDs that are produced by Mayo, patient education folks. I can give almost every patient walks out of my office, no matter what I'm seeing for, with a CD on guided imagery or meditation of some type, because I think everybody has to have some component of stress management as part of their overall health and wellness strategy. Mayo Clinic Book of Alternative Medicine. The medical editor, you may say, wait a minute, you didn't disclose any financial relationships. You must be making money off the book. Fortunately, Mayo is very pure, so even though I wrote most of the book and did a lot of work on it, I don't get any money for it. So I can talk about it, and my program doesn't get any money for it, my department doesn't get any money for it, so I'm very pure. And I'm not necessarily happy about that, but that's a different discussion. But it's a very good book in terms of a very basic introduction. So this is not for your yoga teacher who's been in wellness for 25 years, but for your patient who says, geez, Tai Chi, is that the stuff you drink? Or is that that's a good book for you. Because it can be very basic, but it helps them understand that there's some danger out here, right? You take St. John's wort, you have cyclosporin for your heart transplant, and you mix those two, and all of a sudden your cyclosporin goes down. Case reports of heart transplant rejection, right? So we want to highlight the dangers so their patients don't get in that, but then we want to look at what might be helpful for them as well. And again, not to highlight from a commercial standpoint, these are older, so I'm not recommending you buy them, but these are some wellness videos we did about 5 years ago, 6 years ago. But the point is, when you look at the arthritis video, probably the director of rheumatology talks about arthritis. One of the integrative medicine docs talks about how we can approach it from an integrative standpoint. And then there's a module on yoga, a module on meditation, a module on nutrition. And the point is not that these should be bought anymore, because they're probably outdated, but the point is that at that high, again, institutional level, we're seeing our leadership understand that we can approach these complex problems with an integrated approach. Dr. Sood's book, this is self-published, also not a Mayo book, so it's available on Amazon.com. He takes no profit from it. He puts it all back into a nonprofit. But it's a good place if your patients are interested and they want to know some of the neurobiology, what's going on with this amygdala, why should I worry about my prefrontal cortex, and then have some simple approaches to how to get started in meditation. You say, okay, that's all great, it sounds really cool, but do you walk the walk? So do our employees have access to these types of things? The answer is yes. Our Employee Wellness Center has a number of really cool things, demonstration kitchens, beautiful workout areas. But under the stress management rubric, we've got a number of different massage stations, meditation rooms, yoga, Pilates classes are taught on a regular basis, morning, afternoon, and evening, almost always booked up. And again, you're just starting to see this idea that there's more to how we take care of ourselves than just one strict path. And everybody's different. So I have a lot of folks who don't like yoga, won't do yoga. I have other people who, you couldn't take it away from me if you tried. So again, it's this idea of having choice. How do we find that works for that individual? And maybe it is just going to be the narcotic, and they don't want to have massage after open heart surgery. Perfectly fine. But what if they want to try and, I think having those choices is what we're shooting for. So you won't see this in January, but right now you might see it in Rochester. How does this fit with Mayo Clinic? Well, our primary value, the needs of the patient come first. Sort of sounds like an advertising slogan, but it really is kind of core to the DNA. People really do value their, being at Mayo Clinic and working at Mayo Clinic, and the needs of the patient come first. Well, again, if I have a patient who has pain, who has nausea, and I can't fully, completely take care of it from what I have in my conventional armamentarium, it's really cool to reach back and have something else to offer them. And then we have this healing value statement, which again, I think just kind of resonates with this idea. How do we take care of the whole person? And again, this is where I start to see, well, that was really cool. We did some research. We found something that wasn't available before. We made it available, and some patients are being helped dramatically. So I'll close with kind of how do we go from CAM, which is how we started, to this idea of integrative medicine. I think if you think about it very simplistically, we've got fantastic conventional care, whether you're here in Rochester. What if we have evidence-based CAM that we know could be helpful? And what if we bring the two together? So I'm having my open heart surgery, but I'm also getting massage. Or I have hypertension, I'm taking one pill, but I start learning meditation, I don't have to take a second pill. So integrate the best of both worlds. And I think the definition here is from the Consortium of Academic Health Centers. This is a group of 55 North American medical schools, meet 2 or 3 times a year, run international conferences, do research education and practice discussions. But I think what they're emphasizing here is relationship, that's in there. And I think that's key. Most of us who went into medicine, nursing, take your pick, we went in there because we wanted to help patients. We wanted to have that relationship. We don't want a 10-minute visit, right? So we're going back and honoring that. It's a relationship between practitioner and patient. So that's nurse, that's doctor. It's also acupuncturist, massage therapist. So thinking of more broadly about how do we heal and help patients. The whole person. So again, that whole concept of maybe I need to have some healing space for my patient to do the healing they need to do. It's got to be informed by evidence. And so, what I didn't show you is a lot of the things we're not doing because not because they don't work, but because they haven't been studied enough to know that for sure. So we can't just say, oh, it's cool, it's CAM, let's bring it on because it'll help us sell, more patients will come to Mayo Clinic. You want to be evidence-based because we have to, right? That's our environment in the biomedical realm. But having said that, absence of evidence doesn't mean something couldn't work. So we don't have to go out there and fight against things necessarily. But if there's harm, we will. And if there's not evidence, we can't promote it because we want our patients to be informed. But when there is evidence, we want them to have that information as well. And then let's incorporate all that to optimize healing for that individual patient. So that's kind of my vision of kind of what we've hopefully been doing at Mayo Clinic, addressing an interest, which is probably 40 to 60% of our population, using research to try and address that interest so we know as physicians, caregivers of all stripes, how to interact with our patients, give them information. And at the end of the day, we want to have informed patients so they can make informed decisions, avoid the pitfalls, and get the benefits. So I hope that's helpful. I hope that gives you some thoughts about maybe things you could do in your practice. And I think we'll stop there and open it for questions and any thoughts that you might have that you want to share as well. Thank you very much.
Hello, and thank you very much. But I may have gotten here late, but is there any standardization or any kind of, standardization of massage? What does that mean?
It's a very good question. So, if you think about all these different therapies, acupuncture nationally has a certification, a board, a lot of structures going into acupuncture. So you can go and look up and find things out about the acupuncturists down the street. Massage, not so much. There's some states that have licensure. There's a lot of states that have some credentialing and so forth, but it's still kind of a hodgepodge. They're moving in that direction, but at this point, a lot of people hang out their shingle with very limited training. At Mayo, we've required a certain amount of training, a certain amount of clinical practice, And then especially in the hospital, we have a special class that they have to go through before they can ever touch a patient. So they have to learn about HIPAA. We actually put them in our simulation center with the models that have chest tubes and so forth. How are you going to move around this? When can you massage? When can't you? So to just walk off the street and hire a massage therapist, not a good idea. To develop a program that you can incorporate them as part of the team, wonderful opportunity.
You didn't say anything about chiropractic.
Yeah. So this is one of those ones where, the evidence is really strong for chiropractic for low back pain, especially. Evidence doesn't help as much with chiropractic because of the heat, right? There's this long-standing conventional medicine chiropractors, I hate you. So really, we actually have at least one chiropractor on staff who was a chiropractor, then went on and became an MD, but he practices in PM&R. He and a couple of his DO colleagues do some manipulation. So you could say we are doing, to a certain extent, a little chiropractic. But that energy that goes into, I've got to convince these really stalwart opinions on either end, we probably spend a lot of time, and I don't know we change anything. So we haven't done a lot. The PM&R folks have actually done some stuff in the biomechanics lab looking at cadaver models and pressure and what happens when you do this and that with the manipulations and so forth. So I think it's overcomable, if that's a word, but it's not where I can put a lot of energy because we're such limited resources. We kind of go for the low-hanging fruit, right? Massage, nobody really argues too much about it. I had a massage, I felt pretty good, I'll go ahead and do it. Acupuncture, it's a little funky, but you got some evidence. So those are ones you can win, and we can actually start moving, we can actually translate to patient care right away. I think chiropractic, a lot of places incorporate it. It's just for us, it's been one of those things where its time will come, but not yet, it's my opinion.
I'm a Mayo Clinic alum, and so I hope the following question doesn't get me deactivated from the Brotherhood, but it's controversial and sensitive, but any thoughts about medical marijuana?
Yes. Next question.
Thank you.
So again, lots of thoughts, and it's almost the same answer. We could do a lot of work on medical marijuana, and I could maybe come here and show you, medical marijuana is the greatest thing since sliced bread. It's going to be pretty hard to change a lot of opinions. Vice versa, I can show you, it doesn't really work. It's not that much better for cancer patients than conventional stuff, and I'm not going to convince, so there's one of those ones where you can put a lot of energy, and we're probably not going to be the ones, because we don't have that kind of expertise. It's not like, so that's one where I say, fine, other people are working on that. You figure it out over here, you figure it out over here. We'll learn from you, but we're not going to be the ones that take the lead on that. That's been my personal opinion. Maybe I'm just checking, or maybe it's just a realization we don't have that many resources, and if I try and answer every question, then we don't come back and do the good stuff with what we do have.
Do you have any data on length of stay, cost of stay, things like that as far as the...
Yeah, so that's the holy grail, right? If we had length of stay data, so we did that with one of our massage studies. I think it was in the thoracic folks. The question is, we know we're reducing pain. So one of the things we said, well, I bet you we can show that we're reducing narcotics. If we're reducing narcotics, we're saving money. They probably get out sooner because they poop sooner and all that stuff. So let's look at that. So we looked at narcotic stuff. But in a study of about 150 patients, it turns out that the protocolized approach to pain management with 5 or 6 different surgical teams, we could not do anything. So we could show pain scores down tremendously, couldn't see any change in narcotics. So to be able to look at that, you're going to need much larger numbers. And to be honest, the average length of stay, I don't quote, well, I'm probably being recorded, somewhere in the ballpark, the length of stay for post-operative open heart surgery, about 4.5 days, right? So you're barely getting the chest tubes out, day 2 or 3, and you're practically, so to think that something's going to make a huge impact, probably not. But I'm willing to bet that if we reduce the pain like I think we do, we reduce the anxiety like I think we do, I bet you if you looked at 1,000 patients or 2,000 or 10, you would probably find that there's probably, in the hours, half a day, probably over a large population, you probably could show that. But the challenge, of course, is nobody wants to pay for those studies because that'd be an extremely expensive long-term study. So we're kind of left with these surrogate markers. Did I reduce pain? Did I reduce anxiety? Satisfaction's up. But yeah, the hard questions of length of stay and actual cost. Now, interestingly, one of the things we caused cost with, anybody here using Queasies, the little metal tubes with the, is it peppermint? The stuff for nausea. So you sniff it, it helps with nausea. Well, we started using those gangbusters. We had fantastic results. We did a couple little studies, spread like wildfire through the hospital. And what we didn't realize, well, I didn't realize, they were $9 a pop. And so all of a sudden, people are, wow, and it's not a covered cost. You can't. So, oh God, we're eating lots of. So then we came around and said, well, what about if we just took natural oils, essential oils, put them on a little cotton ball like a lot of other hospitals do? Could we get the same effect? Oh yeah, it works just as well. And the little bottle of natural oil costs, 10 cents. The Queasy's $9. So we switched over to natural oils, and all of a sudden we see costs. We've probably saved ourselves $50, $60, $70,000 just in pediatrics alone. Now, we caused the cost in the first place by introducing Queasy, so you can say, well, that doesn't really count. But I think there are ways that we're going to find cost effectiveness, cost savings, but it's going to take some different ways of looking at the data because it's just so hard to do those studies.
You had a study or two about stress, and I know you didn't show us any of the hard data, but is that measured just on scales of one sort or another, or is it any kind of serological measure that goes along, or your medicine, cortisol, or whatever?
Yep. So great question. So, there's a number of things we do for a lot of these small studies, like with massage, where we're more interested in the patient experience. We'll just use a Likert scale or an analog scale, no stress, 0, worst stress you've ever had, 10. We'll also, for some of the larger studies, we'll use the validated instruments like the perceived stress scale. For some of the other studies, we've got a R01 application in right now to look at what if we brought massage into the hospital setting for nurses, not to reduce their stress, but secondarily, if they were less stressed, would they make better health decisions? Because we know our nurses are extremely unhealthy because they're just working hard and then they go home and work hard. So we're looking at, and that we've embedded the cortisols and some of the interleukins, the anti-inflammatories. But of course, as soon as you start to do that, you increase the cost tremendously. So when we're kind of nickel and diming ourselves on some of these studies where we're trying to do it volunteers or a little benefactor money, we haven't embedded a lot of those serologic markers. Other studies have done that and been able to show that. So for me, it's been more important that I can show that it fits the Mayo model of care, it fits the flow of practice, it didn't hurt anybody, and we saw that patients valued it and we saw satisfaction. That's probably good enough as long as somebody else has done some of that hard work of measuring the cortisols and doing all the challenges there.
Have you done any studies with Healing Touch at Mayo?
Healing Touch. So Healing Touch is another one of those challenging issues. It falls in the scope of practice for nurses in Minnesota, so nurses are able to practice Healing Touch. Our nursing leadership kind of goes back and forth. Sometimes they support it, sometimes they don't. I wait for nurses because I don't want to ever step across the toes of a nurse. So until our nursing leadership figures out what they're going to do, it's sort of a don't ask, don't tell. They've been offering it, but you kind of have to know your buddies on call. Hey, my patient wants it, they call somebody over here. We have done a couple studies. We did one with prostate cancer patients getting radiation therapy, brought a therapeutic touch person in, and she's still sitting on the data. She hasn't written it up yet, but just looking at it, it's very positive in terms of relaxation, stress reduction. Now, we've actually gone to the point where we're offering Reiki through our volunteers. So Reiki is another form of energy manipulation, energy healing, and because it's being offered as a volunteer service, again, they have to be credentialed and certified and all those things. But now we have a cadre of nurses and some community folks who are offering Reiki as a volunteer. But again, it's one of those challenging areas to study, right? Because as soon as you try and use touch, and for those of you who don't know these energy, this isn't touching the patient for the most part. It's usually fingers above the patient, an inch or two, and then my energy, your energy. We have to kind of get things. It's very hard to conceptualize for most Western docs, and it's also extremely impossible to measure, right? Because we can't measure those fields. Those are not biofields like we're familiar with. So the challenges in the research there have been very high. Risk is very low, so this is one of those areas where sometimes you have to say, don't have all the evidence for efficacy, don't have much risk for harm, then it becomes more of a personal choice of how we approach that. Is that it? All questions answered? I'll hang out for a few minutes, got my email. Thank you so much. Very nice to be here.